Good afternoon, everyone, and thanks for joining us today. I am Ankit Dogra with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services, Jagsonpal Pharmaceuticals Ltd, and Mr. Kamal Singh Bisht, Regional Manager based at Western UP and Uttarakhand from Jagsonpal Pharma Sales Team. We all welcome you to today's episode of High Risk Pregnancy Update Series, organized by West UP chapter of ISOPARB with academic partner Jagsonpal Pharmaceuticals Ltd, makers of DIVATRONE, 10 mg tablets of micronized dydrogesterone, indigenous and affordable for a smoother and safer journey to motherhood. We also present JP Tone iron syrup, enriched with zinc and vitamin B complex. A warm and hearty welcome to all the esteemed faculty members and the attendees. Dear attendees, we request you to post your queries by text in the Q&A box. Please note this webinar is streaming live on Facebook and the link is shared in the chat box. To refer to this webinar in future, please visit our YouTube channel Jagsonpal Medical Insights, as the recording of today's program will be uploaded there. We gladly welcome our Masters of Ceremony for today. Dr. Ritu M. Arya, she is Secretary, Khoda Makanpur ObGy Society. Dr. Neha Gupta, who is on the editorial board of West UP chapter ISOPARB, and Dr. Amber H. Khan, Secretary, Jaunpur ObGy Society. Now we request the convener of program, Dr. Seema Vashni, Secretary, West UP chapter ISOPARB, to kindly take the proceedings further. Over to you, ma'am.
Thank you for your kind introduction. And I myself, Dr. Seema Vashni, Secretary, West UP ISOPARB. I extend a very warm welcome to all of you, and my gratitude to Dr. Usha Sharma ma'am, President ISOPARB, and Secretary General Dr. Meena Samant, and Patron Dr. Narendra Malhotra sir, and Padam Shri Professor Dr. Usha Sharma ma'am, and President West UP ISOPARB Dr. Archana Verma ma'am. Today we are blessed with our chief guest Dr. Usha Sharma, President ISOPARB, guest of honor Dr. Archana Verma and Dr. Bipin Pandit, and we all welcome you. And I extend a very warm welcome to all the eminent speakers, chairpersons, and all the delegates who have logged in a very important and although it is not very common, but it is very important and often untouched topic, hemoglobinopathies and sickle cell disease. And I am grateful to Dr. Archana Verma ma'am, who always choose such topic which will be very useful in our day-to-day practice. Very rarely, we come to we face these patients, and we should know how to approach, what are the complications and what are the incidents of the sickle cell disease. So for further proceedings, I hand over to Dr. Ritu Arya, who is a very dynamic secretary of CHAEMOGS, for further proceedings. So Ritu Arya, over to you.
Thank you, ma'am. Thank you. Hemoglobinopathy is a very, it is really a public awareness, public problem, and a common inherited disorder. And the ISOPARB has chosen this a very important topic for us to know about it. And now, before starting the academic session, we'll have a small inauguration ceremony in which we'll invoke Ma Saraswati to seek her blessings.
या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहाम्.
Thank you. Now I'd like to invite Dr. Archana Sharma ma'am, who is the treasurer and founder of ISOPARB West UP chapter, to please welcome our chief guest, Dr. Usha Sharma ma'am, who has given us this platform to enhance our scientific academic careers. Archana Sharma ma'am.
A very good afternoon, everyone. It is really my very proud privilege to introduce President National ISOPARB Chapter 2020-2022, Mrs. Dr. Usha Sharma Madam. She is, I don't think if there is any need of giving introduction. Everybody knows her very well, and she is the President of the National UP ISOPARB, National ISOPARB Society. She is the consultant obstetrician and gynecologist Patna, SK Memorial Hospital and AK Memorial Nursing Home. And I don't think I'll request Madam to say a few.
Yes, thank you. You have said enough. Yes, thank you.
Welcome, Madam. Welcome. Welcome, Madam. Welcome.
Archana, it's so nice to see you.
Ma'am, we are blessed to have you.
You know, no one can speak better, sweeter, and respectfully more than you. This is the award. I think I should be giving it to you. Now I start with my welcome. Okay. I congratulate Dr. Archana Verma, President West UP chapter, and her team. She is also the Vice President of FOGSI at present. For today's webinar, for choosing the theme Update on Hemoglobinopathies. She is an asset to ISOPARB, a lovely, dynamic, and enthusiastic person, always ready for academic pursuits. Vice President FOGSI, a stalwart attending today's webinar as guest of honor. Today's theme, hemoglobinopathies. The cumulative gene frequency of hemoglobinopathies in India is 4.2%. There are over 42 million carriers and over 12,000 infants are born each year with significant hemoglobinopathy. Out of these, thalassemia major and clinically significant sickle cell disorders accounts for almost equal numbers. Today, focus is on sickle cell disease. The sickle gene is widespread among many tribal population in India, with prevalence of 1 to 40%. Co-inheritance of the sickle gene with beta thalassemia, HBD Punjab, and glucose 6 dehydrogenase deficiency has also been reported. Now, sickle cell disease is going to be dealt in detail by the learned speaker, Dr. Anuradha Shrikhande. Dr. Alka, Patankar, Jatkar is going to talk about preconception counseling and prenatal diagnosis of sickle cell disease. Management of pregnant women from conception to delivery is going to be enumerated by Dr. Surekha Pandit. Dr. Nishad is going to tell us how to deal with complications of sickle cell disease during pregnancy. Now we come to the last session, which is about anemia awareness by Dr. Rashmi. I welcome the esteemed chairpersons, Dr. Manisha Agrawal, Dr. Archana Sharma, Dr. Reenu Bansal, Dr. Alka Mittal, and Dr. Namrata Bharadwaj, who will add their expert comments to the deliberations. I am only too happy to say that all the webinar attendees will be wiser in dealing with sickle cell disease and their complication at the end of the session. Happy learning, long live ISOPARB.
Thank you, Usha Sharma ma'am, for the inspiring words. Now I like to invite Dr. Reenu Bansal, who is a treasurer of Nagpur Obs and Gynae Society, to please welcome two stalwarts of FOGSI, Archana Verma ma'am, very dear to me, and Dr. Bipin Pandit. Dr. Reenu Bansal ma'am.
Thank you, ma'am. Thank you, ma'am. Good evening, everyone. I welcome all the dignitaries and the teachers, my friends, and I am profoundly delighted to take an opportunity to introduce our guest of honor for today's evening. Although ma'am needs no introduction, she is none other than Vice President North Zone. She is a good orator, friendly, and a wonderful administrator. Dr. Archana Verma, she is the founder president of West UP ISOPARB chapter. She is advisor UPCOG and organizing chairperson of UPCOG 2020. She was the past president Ghaziabad ObGy Society. I take an opportunity to introduce our guest of honor for today's evening. Although she needs no introduction, she is none other than our Vice President North Zone, India. She is a good orator, friendly, and a well-known administrator also. She is a recognized figure. Dr. Archana Verma, she was the founder president of West UP ISOPARB chapter, advisor UPCOG, and the organizing chairperson UPCOG 2020. She was past president Ghaziabad ObGy Society and the organizing secretary of the North Zone Yuva FOGSI 2016 UPSR. She was organizing secretary midterm UPCOG 2015, chairperson Public Awareness Committee FOGSI 2016 and 18. She was member Rotary Loins Ekta Udan BVP, executive board member for NNF India and executive member Endocrinology Committee SAF FOG. She has got many awards like India Book of Award winner, President FOGSI Best Committee Appreciation Award, UP Governor RTI Uttarakhand Governor Appreciation Award for Menstrual Hygiene. She has got Appreciation Award from CRPF Director for Health Program 2019. She has got Abdul Kalam Excellence Award and V for Istri Award by FOGSI President 2019. Well, Women of the Year Health Award from IAS Wives Association, and she has published she has been the faculty in 600 plus national and international CMEs and champion of FOGSI 2019. Welcome, Dr. Archana Verma, ma'am, for the kind blessings and share your blessings.
Thank you. Thank you, dear. I think there's even some problem here also in Wi-Fi. Am I audible nicely?
Yes,
ma'am.
You are audible. Very much audible.
This February month is, I really like this one of all because of the good environment and all this thing. In north, the mausam is so suhana, and because abhi Basant Panchami bhi hokar gayi hai. So my salute to my Guru and my Saraswati, Usha Sharma Madam ji, our chief guest. And because in the Valentine Day, the red roses and the red cheeks are should be there. And we all gynecologists are concerned for the good hemoglobin. So whatever is a cause for low hemoglobin in our body, we should talk about it. And this is the month where we should take much aware our women for their health, because खाली रोज लेने से काम नहीं चलेगा. We have to take care of our health. That is a main thing, main issue, and we have to teach our partners this also. Our health is so much important than Mauj Masti. And today, because it is a matter of immense pleasure and privilege to welcome on everybody, especially I am so much thankful to Dr. Rashmi from Amravati. This Amravati is a place very, very close to my heart once again from Maharashtra. And Rashmi has somehow came forward to manage this webinar mainly. And she has asked all the eminent faculty who will be taking all the updates, and they will be awareing all and how to manage and how to take care of all these hemoglobinopathies, because somehow in our life we don't even think what is good and how can we lower the incidence, what is our what should be steps which we should take as a gynecologist to avoid this and to lessen its incidence, because so much thing is in our hands if we aware because of its treatment is nothing. It is mainly the prevention is treatment. And so this is required, and because last few months have been full of pandemic and all the terror and horror. So and this year West UP ISOPARB has done many wonderful activities to the maximum, I must say, and so much thankful to my team, especially Seema Vashne, And this is really sometimes, online, I always take this opportunity to thank my team, because nowadays we are not meeting. So all the MOCs, dear Ritu, dear Amba, dear Neha, thank you for doing all the wonderful work. And this especially the national level faculty from Maharashtra, I'm so much thankful to them. And I think today's webinar will open many of your all the queries, and we will be able to manage it much better way. And this will definitely satisfy ourselves and our what we want to know about it. And so my gratitude to all of you and all the faculties and Jagsonpal Deepika for always coming forward to do whatever I want in whatever way. I'm really thankful to Deepika. Deepika, तो मुझे लग रहा है कि मेरे लिए that वो power backup होता है ना, every time mobile के साथ चलता है, so that is, she's like that for me. And thank you very much, dear team. Thank you very much. And this is my request now from every one from our team. भैया मुझे guest of honor मुझे ना बनाओ. I'm one of the organizing team, and please be I am with you only. This take this as a president address, not as a guest of honor. This is my earnest request. And from next time, जो भी बनाएगा वो guest of honor में मुझे नहीं डालेगा. There's so many big people. Thank you very much. और उषा मैडम, आपका साथ जितना चाहिए, जैसे अभी मेरा थोड़ा सा उधर पटना आने का भी हो नहीं पा रहा था, तो आई थिंक इफ आई गो टू AICOG and you are also coming, otherwise I want to call you to Delhi. Just let the thing.
आप वाराणसी आइए अर्चना जी.
ओ मैम, वहाँ तो आ ही रहे हैं, वो तो
बस वहाँ बहुत अच्छा मुलाकात होगा.
ओके मैम, थैंक यू मैम. Everybody, all of you should also plan to join the annual ISOPARB in Varanasi.
Yes, Varanasi is going to be a real something to remember.
Yes, and because this is a latest hot place to travel also. So
yes, Modi ji has brought so many changes. We need to see that as well.
Yes. So सुन लो दीपिका, अगला वाला हम लोग उधर ही जा रहे हैं.
6 to 8 May. 6 May to 8 May. Please remember these dates.
Definitely मेरा पैर बिल्कुल ठीक हो जाएगा.
Oh, you will be running by then.
हाँ या आपकी blessings और गंगा माता की blessings will be with us. Thank you.
Thank you, ma'am, for the blessings. Now I invite second guest of honor, Dr. Bipin Pandit. Sir,
आगे क्या? पहले उनको कॉल करें.
He hasn't joined, ma'am.
He has
चलो
joined.
उनको introduce करो तब तक.
Okay. Sir, he is a practicing obstetrician and gynecologist and director of Mukund Hospital. He has passed MD and DGO DFP from Seth GS Medical College and KEM Hospital. He is the honorable gynecologist at Dr. LH Hiranandani Hospital, Powai. He is the honorable gynecologist at Seven Hills Hospital, Maroon. He is the past gynecologist at Dr. R.N. Cooper Hospital. He is the former Executive Council member of Maharashtra Medical Council. He is Vice President FOGSI 2021 and the past President of Mumbai ObGy Society from 2018 to 2019. Past Joint Secretary FOGSI and Treasurer AICOG 2013. He is the Chairman Violence Against Doctors Cell FOGSI, the past President of Association of Medical Consultants Mumbai. He has done many publications and presentations and published a book, DocuSmart, on ideal documentation. So welcome, sir.
Thank you, Seema ma'am, and thank you, Dr. Ritu. So with this, we end our inaugural session, and I hope Dr. Bipin Pandit sir would be joining, and then we can have sir to speak a few words for us. The first session is on introduction and overview of sickle cell disease, and we have, for which I would like to welcome Dr. Manisha Agrawal, ma'am. She's a senior consultant. Can we have the slides being displayed? Yeah. So I would request our esteemed chairperson, Dr. Manisha Agrawal, ma'am. She is the executive member of Ghaziabad Obs and Gynae Society. She's the coordinator of IMA Shakti Ghaziabad. She's also the founder trustee of Beautiful Tomorrow Trust. She's a private practitioner in Ghaziabad. I request her to welcome the first speaker of the session, Dr. Anuradha Shrikhande, madam.
Very good afternoon to all, and special regards to Usha ji and Archana ji. I feel honored in introducing a dignitary like Dr. Anuradha Shrikhande. She is Dean, IGMC Nagpur. She is Project Director, Regional Hemoglobinopathy Detection and Management Center, IGMC Nagpur. She is President, Sickle Cell Association Nagpur since 2004. She is a member of SCDIO GSCDM. She has attended various national and international conferences as guest faculty and organized various conferences as secretary. She has also authored chapters on sickle cell disease and various research articles and technical manual for healthcare workers, technicians. She has numerous awards to her credit. Name some of few: Navdurga Awards and Lifetime Achievement Award. Ma'am, we want to know much more from your detailed experience and wide knowledge. Please enlighten us, Dr. Radha Shrikhande.
At the outset, let me thank Rashmi, who was instrumental in coordinating this webinar today. We had our last webinar for Chandrapur district, and during that webinar, immediately after that, Rashmi contacted us, and it is because of her efforts that we are today with you all. We are very fortunate to have with us Madam Usha and Madam Archana, and all dignitaries from the UP chapter of ISOPARB. We wish you all the best of luck, and it is nice of you to have arranged this topic on hemoglobinopathies, which is new to this particular geographical zone. Sickle cell disease, we have been working for last 28 to 22 years, and it is important because we have a tremendous load of this inherited disorder. This is a kind of hemolytic anemia. It runs in the families, and then the best way to control this disease is prevention. This is only possible if we are all aware of what this disease is and what it means to women. Can I have the next slide, please? Our effort starts with giving equal opportunities in governance and development to women, because women can pull children, families, more women into an expanding circle of benefits that features education, healthcare, employment, and peace. And women use creative non-violence to prosper and protest. Empowered women mean empowered societies. We firmly believe in this, and with this idea engraved in our minds, we wanted to empower our sickle cell mothers so they are in a better position to take care of their children who are the sufferers of the disease. With this idea in mind, the state of Maharashtra started its pilot project, which was called as Regional Hemoglobinopathy and Detection Center, at one of the government hospitals in Maharashtra in Nagpur city, that is called Indira Gandhi Government Medical College. And we had this pilot project way back in 1998. And the whole idea was to start and encourage women and in general population to know what sickle cell disease is. Next slide, please. As I had already said, that it's a disease which is not restricted to a particular geographic zone in India, but it's a global problem, and it coincides with all the hyperendemic zone for malaria. Next slide. And it is not only, next slide please, it is not only sickle cell disease, but there are other variants which are equally important. As far as your region is concerned, sickle cell disease may not be that common, but other variants, other important variants which are clinically significant, like hemoglobin D and thalassemias and hemoglobin E, could be more relevant to you as well. Because of migration of the population, we cannot dogmatically say that sickle cell disease is restricted only to central India. Can I have the next slide, please? But then because of the migratory population, the disease is seen in rest of the geographic zones of India as well. It is more commonly seen in central India. We have a huge population of sickle cell disease patients as well as thalassemic patients in central India. Down south, but then we have other pockets in northern India as well as in eastern part of our map. And along with this, we have hemoglobin D and hemoglobin E. Next slide. Central India is more prevalent with this inherited disorder. It comes in the form of hemolytic anemia. Patients usually come to you with jaundice. They come to you with repeated joint pains. They come to you with infections. And the lifespan generally usually extends, say, up to the 4th decade of life. With the advent of molecular biology and with the advent and the knowledge of sickle cell disease at the molecular level, new drugs have come up in the market, and as a result of which the quality of life of sickle cell disease patients has improved tremendously. Since it's an inherited disorder, it starts with birth and remains with you till you die. In between, it is the duty of we as medical fraternity to make the population aware of what they are suffering from and give them a quality life. Next slide, please. In India, especially in central India, the gene frequency ranges somewhere between 10% to 40% in neighboring districts of Vidarbha. As far as Chandrapur and Gadchiroli districts, where the tribal population is maximum, the gene frequency ranges somewhere between 22 to 38%. It is very high. Next slide. In order to find out what is the gene frequency, we must have some knowledge of the vital statistics and the population and the female population, especially since we are concentrating on women today. We must know what is the population of females in both the rural as well as the urban settings. I'm talking of Maharashtra here, that the majority population of tribals is present in the rural area, and the women are also more compared to the urban population in the rural settings. Why it is important to note this is that sickle cell disease is seen in tribal populations predominantly. This is the population which is socioeconomically underprivileged. They are marginalized from the mainstream. The literacy level of this particular population is low, and so they do not have their own voice as against what we see with thalassemic population. Thalassemics usually are seen in educated and well-to-do ethnic groups like Punjabis, Marwadis, Bengalis, whereas sickle cell disease is predominantly seen in scheduled caste, scheduled tribes, and other backward communities. Because of the intercaste marriages, there are other caste systems as well nowadays that we can get sickle cell disease seen in them. Next slide. In order to find out what is the next slide, please. In order to find out what is the birth rate as well as the number of homozygous as well as the heterozygous carriers in a population, the anthropologists use what is known as an Hardy-Weinberg law. And this uses the gene frequency, next slide, takes into consideration the birth of the newborn, which are born with sickle cell disease, as well as the carriers which are born with sickle cell disease. And then next slide, please. The number of population that we are going to have per year who is going to be affected by sickle cell disease is calculated. This is important because if we want to have the health policies being made for sickle cell disease patients, and which seems to be a priority these days, in that case, we must have some estimates of what is exactly the number which is going to be affected and who are going to be the homozygous patients and the carriers. As we all know that homozygous patient is the one where the abnormal gene is being carried by both the parents. That is, both the parents, they transfer the abnormal gene in the offspring, and then a homozygous child is born. Whereas a heterozygous carrier is the one where only the abnormal gene is transferred by either a mother or father. What is the difference and why it is important to know both these patterns is because homozygous patients are the ones who would be symptomatic. They would report to the hospital. But equally important is the heterozygous or the carriers who are the silent carriers of the disease, and they are the ones who can transmit the disease to the next generation. Next slide. So the sickle gene frequency, as I had already said, ranges somewhere between 10 to 30%. A geographic zone which has a population of more than 10% is considered to be a high-risk zone, and therefore it becomes very important for India to have its own sickle cell control program, where we are in a position to take care of all the homozygous births that have already taken place. At the same time, we must have a very effective preventive program so that we take care that no child is born with sickle cell disease. And here comes the role of gynecologists and obstetricians, where they must be aware of what sickle cell disease is, what does pre-marriage counseling mean, what does a pregnant mother screening mean, what does screening of the partner means, and what is the appropriate time, and what are the counselings that should be offered to these ladies when they are first reported to your places. And that is why we have been organizing these seminars, not only for the general public, but then we are organizing regularly these seminars for the gynecologists and the obstetricians along with pediatricians, so that even if a child is born in a gynae and a maternity setup, we take care of the newborn who is born there and offer them comprehensive healthcare plan. Next slide. Primarily, we are dealing with this tribal population, next slide, who are socio-economically disadvantaged. Next slide. The disease has a variable pattern because what we harbor in our patients is the Indian haplotype. It is called as the Arab Indian haplotype. Everyone amongst this population, everyone amongst this August gathering who is attending this webinar knows that sickle hemoglobin is an abnormal hemoglobin formed because of a constitution of just one single amino acid which is being changed, as a result of which you get this abnormal hemoglobin. And as a result of this abnormal hemoglobin, all the other clinical symptomatology occurs on when there is low oxygen tension in the body. So a clinical picture varies from a very, very mild pattern, asymptomatic homozygous sickle cell patients who would be reporting to you for delivery. They are harboring this SS pattern. And if we are not aware of the condition that such type of screening is necessary when a pregnant mother comes to a setup of obstetrician, then maybe she would just pass on without any knowledge, and she may give birth to sickle cell children. Next slide. As against this, we already have elderly pregnant sicklers who also go unnoticed. They are multiparas and they go on producing children if they are not detected in the very first meeting when they attend the ANC clinic. In that situation, it is very likely that they will go on producing both homozygous as well as the heterozygous children. It is very unfortunate, and it is very likely in all this tribal population because they hardly have any medical facility available there, and they go on producing children with homozygous sickle cell disease. So one has to be aware that this is something which a pregnant mother must get tested for. And during her very first meeting with the obstetrician, what is important is that apart from other ANC checkup, sickle cell testing and thalassemia carrier testing should be one of the tests which should be offered to these ladies, because it is not only important for your region, maybe that you may have less number of sickle homozygous, but then you have hemoglobin D, which is very common there. And because of the migration of the population, some of these sickle cell patients might get migrated. And if you have a compound heterozygosity with sickle and hemoglobin D, you will produce an SD child, and this SD child is clinically symptomatic. So it becomes our responsibility to detect this sickle hemoglobin as well as abnormal variants in a pregnant mother during the first trimester, during her very first visit to a maternity setup. Next slide. Next slide, please. What goes wrong in sickle cell disease, we all know. It is the shape change of the red blood cells. Abnormal hemoglobin resides in these red cells. When the oxygen tension is low, these red cells, they change their shape and they attain a sickle shape. And these abnormal red cells, they block the microvasculature, produce ischemia and necrosis of that part. So this was when 100 years ago, we believed that it is only the shape change which is responsible for all the symptomatology and pathophysiology of sickle cell disease. Over 100 years, with a lot of research going on, next slide, we now know that, next slide please, that it is not only the shape change, next slide, but then it is a multifactorial pathophysiology of sickle cell disease, which is no more restricted only to polymerization of this hemoglobin S under low oxygen pressures, but then it is activation of inflammatory process, activation of coagulation cascade, activation of platelets, and gathering of the adhesion molecules at the site of the insult where there is blockage being produced by these abnormal cells, that this multifactorial process, it plays a major role and it creates this blockage and leads to the pathophysiology which we see in sickle cell disease. Like I already said, that molecules, drug molecules have already come in the market. Hydroxyurea is one such drug which produces large number of hemoglobin F, as a result of which this hemoglobin F is in a position to tackle the side effects of hemoglobin S in a given population. So when we identify our patients right at birth, at newborn period, then over a period of time, when these children usually develop symptoms around 18 months to 2 years of age, we already have a drug molecule available with us, and patients can be put on comprehensive health plan, and they can be given a better quality of life, better pain-free life. Usually these patients, they experience this painful crisis during their lifetime because of the blockage of these abnormal red blood cells. So symptomatology complex is revolving around the pain crisis, along the infections that these patients have, and then the complications which are present right from the day they are presenting with their first pain crisis till they develop multi-organ damage. Next slide, please. Indian sickle cell disease, the Arab Indian haplotype, is characterized by very high fetal hemoglobin, and that is the reason why some of our pregnant mothers may not have any symptoms, or this tribal population, they get used to minor aches and pains, and so they never report to the gynecologist or to the physician telling coming with their symptoms. And it is for us to keep this in mind, that probably we have to first rule out sickle cell disease or other hemoglobinopathies, even though they are asymptomatic. So as a part of routine investigation procedure, one must go ahead and screen for hemoglobinopathies either before marriage or at the first pregnancy when they visit our setup for the first time. Splenomegaly is very common in our patients because we have interactions with thalassemias. So that is why they get splenomegaly, as against the textbook picture saying that usually the spleens are infarcted and they undergo necrosis and fibrosis. But we find that in central India, we get splenomegaly as a common feature with our sickle cell disease. Compared to the African counterpart, leg ulcers and priapisms are very rare in our patients, but then bone crises are very common. They may come with a vascular necrosis in shoulder, in hip joints, or sometimes maybe in other bones of the body, which could lead to a handicap situation for these patients, and they may be limping all throughout their life. Next slide. Pregnancy and sickle cell disease poses a special problem, and we would be focusing our attention on pregnancy itself. Other stalwarts in today's webinar, they will be highlighting about the trimester-wise management of pregnancy as well as complications that occur during pregnancy. But for me, it is important to just tell you here right in the beginning that compared to sickle cell heterozygous and compared to a control population, anemia is much more common and much more presenting symptom in pregnant sickle cell patients. And it is of such severe degree that sometimes it may require even blood transfusions. Hemoglobin F, as I had already said, is very high, to the tune of 24%. Normally, the hemoglobin F in an adult is around 4 to 5%, but in our situations, in pregnant females, in sickle cell disease, we may get a hemoglobin F of up to 24%, and which offers some protection. Alpha thalassemia is also very commonly seen in our population, and alpha thalassemia also helps in ameliorating the complications which are seen in sickle cell disease. As far as conception is concerned, it is delayed, and patients may even, the female population may even show delayed menarche. Next slide. During pregnancy, patients experience pulmonary pregnancy-induced hypertension, repeated urinary tract infections, preterm labor, intrauterine growth retardation, and then low birth weight babies. And in order to have a baby which is healthy, one must start taking care of these women with special categories right from the day of conception. Next slide. Even though the disease was recognized,
Ma'am,
100
kindly
years
restrict
back.
your time, please, ma'am.
Yeah, next slide, please. Just last 2-3 slides. Government of Maharashtra has come out with sickle cell control programs. So now with all government hospitals, we have a concrete sickle cell control program where free testing, management, and counseling is being offered. Next slide, please. With identification by WHO as well as United Nations that sickle cell disease is a public health problem. And so with this recognition, there are efforts to reduce the burden of disease globally. Next slide, please. And so more attention is being focused on sickle cell disease. And therefore, we need to adopt a 3P formulas where premarital screening. So each and every adolescent boy and girl must know what is their sickle cell status. Pregnant mother screening, each ANC mother must get her testing done. If she is positive, her husband should also be tested. And there should be facility available for prenatal diagnosis. Next slide, please. Instead of matching the horoscopes before marriage, it becomes mandatory that we test the blood sample for the carrier status of either sickle cell disease or thalassemias. Next slide, please. This would help us to avoid marriages and offer counseling to our carriers to plan their pregnancy and to plan for prenatal diagnosis. Previously, there was a dictum to blanketly say that no carrier should marry a carrier, but this has resulted in marginalization of the females and stigmatization of the females. And so our focus nowadays is on prenatal diagnosis. If we want to prevent the birth and if we want pregnant mothers and marriageable youth to come forward for screening, we must have effective prenatal diagnostic facilities. Alka will be highlighting more on this, so I will not dwell more into this. Yeah. Next slide, please. Next slide. Next slide. There are some social issues which have raised because of our advocacy programs about carriers should marry a normal person. That has resulted in stigmatization. Next slide, please. Next slide. Mass marriage programs which government promotes, awareness about all these hemoglobinopathies and about prenatal diagnosis should be made. Next slide. And then only acceptability for prenatal diagnosis would be there, and that is the role of the gynecologists and the obstetricians. They become the stakeholders to create this site of awareness amongst the general population, so that during these mass awareness programs, we make the population aware of hemoglobinopathies and the ways to tackle hemoglobinopathies. Next slide. So prevention, next slide, please. Prevention becomes the key, and marriage counseling, prenatal diagnosis, and neonatal screening is the key point for controlling sickle cell disease. A word about neonatal screening is that all these babies which are unfortunately born in the hospital setups, they must not leave the hospital unless and until they get tested for newborn screening. For sickle cell disease, it is very simple. You get results before the child is discharged from the hospital. And so effectively, we can put these children into comprehensive health plan and at least give them a better quality of life. So both the gynecologists and the obstetricians, as well as the pediatricians, they become very important for our control program for sickle cell disease. And that is why these awareness campaigns have been arranged. I am again thankful to the organizers for arranging this webinar and giving us an opportunity to share some of our views with you all. Thank you so much. If there are any questions, I would be glad to answer right now or maybe at the end.
Thank you, ma'am. I think questions
I have
and
to say
answers.
something. I have to say
Question
something.
will be asked in the later part.
I have a very special note of thanks for respected Dr. Shrikhande madam. Why? Because she is in USA at present, and due to the difference of time zone, it must be midnight or early morning, I think. But madam,
it is 2:25 a.m. It is 2:25 a.m. here.
We are really grateful to ma'am, Dr. Anuradha.
Thank you so much.
She is so much dedicated to the cause that she instantly agreed to our request. I'm very much thankful to her. Thank you, ma'am.
Thank you.
And for excellent oration, ma'am. Thank you so much, ma'am.
Thank you so much. Thanks a lot.
Thank you, ma'am. We are overwhelmed with your dedication and we are all inspired to work similarly towards the cause. And thank you for the comprehensive overview. With this, we end the first session. Thank you, Chairperson Dr. Manisha, ma'am. Can we have the slides on display? With this we move to the session 2 of our program, and for which I request our chairperson, Dr. Archana Sharma, ma'am. Hello.
Yes, you are audible, Dr. Neha.
Yes, ma'am. I was requesting somebody to display the slides as well. Dr. Archana Sharma, ma'am, is a senior
Dr.
consultant.
Deepika, please display the CV.
And a laparoscopic surgeon. She's the director of Ganesh Hospital, Ghaziabad. She was the past president of Ghaziabad Obs and Gynae Society, and she's also the treasurer of West UP ISOPARB. Welcome, ma'am. Thank you. I would request you to call our speaker for this session, Dr. Alka Jatkar, ma'am.
Okay, thank you very much. Good afternoon, all. First of all, I'll welcome on behalf of ISOPARB and thank our National President ISOPARB, Dr. Usha Sharma, Madam, Dr. Archana Verma, Seema, Ritu, everybody for giving me the opportunity to chair this session. I know that second topic is very, very important and we all should know how to counsel our young couple. As Madam Anuradha has also highlighted upon this thing. Preconceptional counseling is a very important part of the fertility journey of a lady, especially counseling about the hemoglobinopathies. So we are having a very learned speaker for that. That is Dr. Alka Murlidhar. Can you please display the slides of Madam? She is the assistant.
It's already displayed, Madam. Dr. Archana, ma'am.
Okay. Dr. Alka is the Associate Professor of Obstetric Gynecology, Indira Gandhi Government Medical College. And she is having experience of around 28 years of teaching and specialty is trained in the prenatal diagnostic technique from ICMR Mumbai. She has also conducted around 450 Korean village biopsy sampling and amniocentesis for prenatal diagnosis of the sickle cell hemoglobinopathy and thalassemia in the all government medical college. And she is the recipient of Lokmat Maharashtrian Award 2021. Welcome, madam. Over to you now. Dr. Alka Murlidhar.
Good afternoon. Good afternoon, all the dignitaries and my dear friends. At the outset, I would like to thank the organizers for giving me this opportunity. Special thanks to Rashmi for organizing all these things and coordinating all these things. Prenatal diagnosis and preconceptional counseling in sickle cell anemia. The topic very near to my heart. Next slide, please. A little bit of background, even though Madam Shrikhande has covered it in detail, I will just highlight few points. Sickle hemoglobin, that is HbS. Where lies the defect? The defect lies in the amino acid sequence of beta chain at 6 position. What happens? Glutamic acid is replaced by valine. All this we read in pathology. HbS gets precipitated at low hemoglobin oxygen tension and becomes thread-like filament, and it stretches the red cell membrane and make it sickle shape instead of round. And what happens? The total duration of life of the RBCs diminishes. Patient has hemolysis, development of anemia. So sickle gene is widely prevalent. Sickle gene, that is HBB, is located on short arm of chromosome 11 at position 15.5. It is autosomal recessive inheritance. AS, sickle cell trait, goes undetected throughout the life. Heterozygous condition, totally asymptomatic. But if it happens to be SS, that is sickle cell disease, homozygous condition, then the life is very miserable, symptomatic right from birth till throughout the life. And if the patient is female and she becomes pregnant, then we have seen so many mishaps occurring when everything is going well. So minor mutation gives lifelong misery to such patients. So how we as obstetricians can be of help for these patients? Remedy is of any disease. We have learned remedy is prevention of disease. How can we prevent this transmission of the gene and occurrence of homozygous state? First is carrier identification. This can be done by doing the cord blood sampling and testing right at the birth. If not done at that time, when the children are taken for any immunization or pediatric checkup, they should be screened. This is especially so in our area, that is Vidarbha, Maharashtra, the adjoining states of MP and Chhattisgarh, where the gene is highly prevalent. So genetic counseling will be offered even before they go for marriage, so that AS should not marry a AS, so that there will be no risk of transmitting the gene from both the partners and getting a homozygous state. But this is a bit difficult to achieve. So what lies in our hand at present is offering them a prenatal diagnosis. It offers choice to the couples. You will all agree to me that it is a solution far from ideal, because every pregnancy patient wants that she should have a healthy baby, right from the time of conception or even before planning the pregnancy. They plan to have a healthy baby. But if it comes as a shock to her that during antenatal screening, they are found to have both to be carriers, and they are given a risk that 25% chance the child born will be SS, that is homozygous, the choice with you is to go ahead with prenatal diagnosis. And if at all the report comes as SS, you are left with the option of aborting that pregnancy. So even though theoretically it is very easy to say that it's prenatal diagnosis to be offered, but it is very difficult for the patients to accept it. And here lies the art of counseling the patient, telling them that the risk is only 25%. 50%, the conceptus will be like you, that is AS pattern, and 25% it will be totally normal, that is AA. So this solution is far from ideal, involves moral, legal, technical, financial issues, but sole option available till advances in gene therapy are available and affordable to all. Next, please. So what are the indications? To which couples I am going to offer the choice of prenatal diagnosis? Husband and wife, both are sickle cell trait, that is heterozygous carriers. Husband and wife, if one of them is sickle cell trait, but other one is carrier of thalassemia trait, HBC trait, or Punjab hemoglobin, which may be seen in your area. If husband and wife, one is sickle cell disease, that is SS, and other is carrier, then I have to offer them the prenatal diagnosis. And hence, as I told you, there is a need for even before going ahead with the test, you have to counsel them, because I have come across many patients who undergo the test. But one patient, she was Christian, And in Christianity, medical termination of pregnancy is not permitted. So the parents were having one child affected SS. They underwent prenatal diagnosis. The report came as SS, but their parents came and they said that no MTP, we will continue with the pregnancy. Then it is quite painful that even though the procedures are without risk, but there is 0.1% risk of loss of pregnancy, which is there and which that patient will be, you cannot predict it. So counseling before undertaking the test is very important. I have to ask them whether you are ready to undergo termination of pregnancy if the report comes as SS. Modalities of prenatal diagnosis that are available are chorioambular sampling, amniocentesis, fetal blood sampling, that is chordocentesis. In era of ART, pre-implantation genetic diagnosis should be offered to them. If they are going ahead with ART, I won't be talking on this. And NIPS, as the name says, that non-invasive prenatal, it's a screening procedure. It's not diagnostic. It is done, advocated only to reduce the number of invasive procedures, even in case of sickle cell anemia, like in case of aneuploidies, because if the report of NIPS comes as positive, that is SS, then I have to confirm it by doing the invasive test. Next, please. Coming to chorioambular sampling. There are two approaches, transabdominal and transcervical. But as you all are aware that transcervical, as it is associated with more cramping and bleeding, nobody is as of practicing the transcervical approach. Most of the centers, they are doing transabdominal. It is done between 11 to 14 weeks of pregnancy, not before 10 weeks, because there are associated complications of limb reduction defects, and should be done after 11 weeks. And I prefer to do it after 11 weeks because I get an opportunity to do the NTNB scan. Then locate the chorion. Which placentas are very easy to sample? If the uterus is anteverted or mid position with anterior placenta, or even with posterior placenta, it is very easy to access it. Retroverted with anterior, again, it is very easy, but if it is posterior, then it becomes difficult many times to approach the placenta at an earlier gestation, that is at 11 weeks. Then in such patients, I call them at a later date, that is at around 12 to 13 weeks, when the uterus rises a bit in the abdomen and the placenta becomes easily accessible to me to approach by transabdominal route. Then the abdomen is cleaned with betadine first, then sterilium, I clean it. Even the probe is cleaned with the sterilium, and we decide the trajectory of the needle. It should be always parallel to the long axis of the trophoblast and should be entering the trophoblast where it is thickest, so that there is no chance that I won't get the sample. Single needle approach is the preferred one, where we use 20 gauge top needle. Some use double needle approach, where 18 gauge needle is put first into the chorion frondosum, and through it the 20 gauge needle is put, and sampling is done by making to and fro movements after attaching a 10 ml syringe to the syringe and creating a negative pressure in it. This is advocated for the beginners, where if in one pass you do not get good sample, with 18 number needle in place, you can make passes so that you are not piercing the uterus twice. You are introducing your needle through the same 18 number gauge needle, which is there in place in the chorion frondosum. Some use biopsy guide with computer generated needle path. It is good to actually trace the path of the needle. But what happens once the needle is in, the to and fro movement of the syringe, that guide becomes a hindrance in the to and fro movement. So it is not used by many. Next, please. This is the diagram just showing that how to hold the probe and how to introduce the needle just by the side of the probe, very perpendicular to it, but see to it that the needle traverses parallel to the trophoblastic plate. Next, please. Transcervical CVS. Here again, the cervix and vagina are cleaned with betadine. Tinaculum, initially I learned this technique because it was available in my native place, that is Nagpur. But I did not find it very comfortable because most of the patients had bleeding per vagina. In this, tinaculum is not applied to the cervix directly. A polyethylene catheter 16 gauge is introduced and 20 ml syringe is attached to it, and this is also done under USG guidance, and negative suction is done to get the villi. Next, please. CVS and twin pregnancy. We have done 2 twin pregnancies. For this, it is very important that location of individual chorion frontosome is done. Chorionicity is established. If it is a single chorion, that is monochorionic, you have to sample only one placenta. If it is dichorionic, needles are to be put on the thickest part, and here I have to scan in both the transverse and the longitudinal plane so that I find the thickest part of the chorion frontosome, and I have to put the needle near to the insertion of the cord so that I am sure that I am traversing 2 chorionic frontosomes separately and not near the membrane. Otherwise, there will occur mixing of the genetic material of the 2 fetuses. To avoid this, I have to sample the placenta at the thickest and near to the insertion of the cord. That is the precaution that is to be taken care. If any doubt about chorionicity, better go ahead with amniocentesis at a later date. Next, please. After I obtain the sample is taken out in a petri dish containing normal saline. Just confirm by naked eye examination that they are the feathery white villi. Usually this material is having villi, maternal decidual cells and blood, but by naked eye examination, one is able to easily make out whether the villi are there or not. 7 to 8 villi will label the sample to be adequate to obtain adequate DNA material. They are cleaned in the normal saline and transferred in the normal saline. From Nagpur, we are sending the sample to ICMR Mumbai for reporting purposes. Next, please. Amniocentesis. If the patient misses this early period is very important because the bond with the pregnancy is not that thick when it is already in the 2nd trimester. That is the time of amniocentesis, because by that time the patient starts perceiving fetal movements and hence the emotional bonding is more. So it is always better that the patient is referred earlier, that is in the 1st generation. Amniocentesis is done between 15 and 18 weeks of gestation. Detailed ultrasound is again done to locate the placenta. Decide the site of entry of the needle. It should be away from the fetal face, umbilical cord and the placenta. I have to apply the antiseptic solution. Here we use 22 gauge needle, that is this normal spinal needle. After introducing the needle under USG guidance, the stellate is removed. A 5 cc syringe is attached to it and initial 2 ml of the amniotic fluid is withdrawn and it is discarded because it may be contaminated by maternal blood. And after that, another fresh syringe, that is 20 cc syringe, is attached and we withdraw usually 20 ml of amniotic fluid and send it for testing. Next, please. Next. This is just a picture depicting how to introduce the needle. What is the lab work that is done on chorionic villi and amniotic fluid? DNA is extracted and it has to undergo a quality and quantity check whether the quantity and quality of the DNA extracted is adequate and good enough. Then it has to go a amplification refractory mutation system through which it is run. Then it is run through the covalent reverse dot blot hybridization technique, and ultimately VNTR is done, that is the variable number tandem repeat, to rule out any maternal contamination, and then the report is given. Usually we get the report in 5 to 7 days. Next, please. Complications, pregnancy loss and safety of the procedure. Usually associated with vaginal bleeding. That too I told you, if we take an approach of transcervical, till date no patient had experienced any bleeding per vagina and there are no pregnancy losses at our center. Limb reduction defects if done before 10 weeks. Procedure related miscarriage immediately after the procedure, it is 0.1 to 0.2%, and miscarriage later but before 24 weeks of gestation, again it is 0.1% for amniocentesis and 0.2% for CVS. Next, please. Fetal blood sampling. Now the scenario had changed. Today only I have done amniocentesis for a patient who had come at 19 weeks because it is included sickle cell disease is a major disability. So I can offer her MTP even beyond 20 weeks. So even if I get a report 1 or 2 days late, that is after crossing 20 weeks, and if it comes positive, I can offer her MTP. So fetal blood sampling done after 18 weeks. Transabdominal, again USG guided. You have to put the needle in the umbilical cord. It is 22 gauge needle, and umbilical vein is targeted 1 centimeter before its insertion into the placenta, because that is the site which is very stable. The cord is very stable at that site. Only 1 ml of blood is withdrawn, and again high performance liquid chromatography is done, and report is available within 24 hours. So initially when the patient used to come late, where we want the report immediately, because for CVS and amnio, for confirmation it may take up to 1 week to 3 weeks to get the report. So in this, again the Bedke-Kluwer test is done to exclude any maternal contamination. We have to follow the puncture site for at least 10 minutes for development of any hematoma, and monitor the fetal heart rate post procedure by ultrasound guidance. Next, please. This is the picture depicting how fetal blood sampling is done, that is cordocentesis. Complications are more. Umbilical cord hematoma seen in 17%, transient fetal bradycardia 3 to 12%. Feto-maternal bleed can occur. Here I will like to mention that if the patient is Rh negative and father is Rh positive, all the procedures that we are doing, we have to give prophylactic anti-D to the patient. Uterine contractions can occur in 7% cases with fetal blood sampling. There is a risk of chorioamnionitis, and fetal loss is from 0.9 to 3.2% in singleton and 8.2% in twins. The reference for these figures is the Donald textbook of ultrasonography. Next slide, please. This is in nutshell about the prenatal invasive diagnostic procedures that are done. First trimester, chorion villus sampling. Second trimester, amniocentesis and fetal blood sampling. Advantage of chorion villus sampling is the emotional bonding, that is with the pregnancy is bit less. The procedure is safer. We get the report with fish within 48 to 72 hours in case of karyotyping, that is aneuploidy, but in case of sickle cell, it takes almost 1 to 3 weeks. Same is true for amniocentesis, 1 to 3 weeks, but in most of the cases by 1 week, the report is available. By fetal blood sampling, we get a report within 48 to 72 hours. Next, please. Preconceptional counseling. This is the upcoming concept that patients are coming for preconceptional counseling. The pregnancy is occurring by choice and not by chance, as is the case we usually see. So who are the one who can motivate the patient to go for preconceptional counseling? It is the pediatrician, under whose treatment the patient is till she achieves adulthood, and later on the physician, who should sensitize the patient that whenever she gets married, she wants to plan a pregnancy, it should be a planned pregnancy, and she has to take a preconceptional counseling with the obstetrician. What all I am supposed to see in evaluation is blood pressure, to see whether she has already developed hypertension, because they are at risk of development of preeclampsia. Check her hemoglobin, because they usually maintain their hemoglobin at around 7 to 8 grams. So I want that the pregnancy should be there once the hemoglobin crosses 8 gram %. Before prescribing iron, they are already overloaded with iron. So check the ferritin level. If the ferritin level are less, then only prescribe her hemoglobin. As patient has childhood, various repeated blood transfusion, she should be screened for hepatitis B and C. B we are routinely doing, C we may not do, but these patients should be especially screened to prevent mother to child transmission. Then she has to discontinue certain medication, because if she is already on hydroxyurea, which is an anti-malignant agent which increases the fetal hemoglobin and improves the quality of life of sickle cell patients, she should discontinue hydroxyurea, because it can have a teratogenic effect, even though till now no case has been reported. And if your patient conceives accidentally, if she is already on hydroxyurea, you have to just counsel her that there is a theoretical risk of teratogenicity, but till now there is no evidence showing any teratogenic effect, even though it is seen in animals. No case is reported in human, and I will not advise medical termination of pregnancy. If she is assessed, her husband is not yet tested, go ahead with the testing of the husband prior to planning a pregnancy, so that they are mentally prepared if he turns out to be a carrier for prenatal diagnosis. See to it that patient, and in discontinuation of medication, if she is already on ACE inhibitors or ARBs, she should discontinue those. Pneumococcal, Haemophilus influenza B vaccine, all encapsulated organisms. She is at risk of acquiring all these infections. So make sure that she has received all these immunization. As in other pregnancies, get her started if they are already on folic acid. If she is not taking, she is irregular, stress that she should take folic acid tablet regularly, take multivitamins, maintain her hemoglobin at 8g%, and then only she should embark on pregnancy. And my friend Dr. Surekha will be talking in detail about this again. Next, please. So I will like to end by saying, may you be proud of the work you do, the person you are, and the difference you make. By being a very vigilant obstetrician, you can really bring joy in the life of a sickle cell disease woman. Thank you. Thank you so much for your patient hearing.
Thank you, madam, for such a wonderful and lucid talk. You have described all the procedures so nicely. As we are running short of time, I think we should move on to the next topic. Dr. Neha, please.
Thank you, ma'am. With this, we end this second session, and I hand over to Dr. Ritu.
Dr. Neha, 1 minute. I think we have Dr. Bipin Pandit. He has logged in. Sir, can we have your blessing, sir? He's there.
Yes, sorry,
yes,
sorry.
No problem, sir.
With...
We all welcome you, sir. So we want to hear some pulse of wisdom, sir.
There are no pulse of wisdom. I was sorry, I was busy with another meeting, so I just got free for another meeting. It's a great job, and thank you very much for inviting me. It's a great pleasure to be with you all. To some time, I was listening to the lectures, and they're very interesting and very informative. And I wish you the best for ISOPARB UP chapter, and thank you very much again for inviting me. Thank you.
Thank you so much. Thank you so much for joining us. Thank you.
Thank you, Bipin sir. Now, after reaching the diagnosis, as we all know, during pregnancy, the disease can become more severe. So how to approach it? I invite Dr. Renu Bansal ma'am, who is a treasurer of Hapur Obs and Gynae Society, to please welcome our speaker. Dr. Deepika, please, slides please. Dr. Renu is practicing in Hapur, and she is an active member of Hapur Menopausal Society and at present treasurer of Hapur Obs and Gynae Society. Ma'am, please welcome Dr. Surekha ma'am for the deliberations.
Good evening, everyone. I welcome Dr. Surekha Taide. She is Professor, Unit Head, JNMC, Varda. Person, Global Women's Health Task Force Network, TUFH USA. She's the founding member and vice chairperson of Women Health Together for the Future, South Africa.
Thank you. I think we should say in brief only.
Welcome,
if I can. Yeah. So thank you very much. Because we are running short of time, so I thought I will just start on with my lecture. With greetings and acknowledging our chief guest, Dr. Usha Sharma ma'am, guest of honor, Dr. Bipin Pandit sir, and Dr. Archana Verma ma'am. And thank you, West UP chapter ISOPARB, for this invitation. I also acknowledge the presence of my teacher, Dr. Alka Jatkar, who has spoken before me, and the great expert and stalwart, Dr. Anuradha Shrikhande. My talk is Approach to Sickle Cell Disease in the 3 trimesters, and greetings from my college, which is Jawaharlal Nehru Medical College. I'm a teacher, trainer, guide since last 20 years, and I present myself to you as a candidate for Clinical Research Committee, FOGSI. So, as we know, the burden of disease is high. We have listened to Dr. Anuradha, who has told us how high the disease burden is, especially in central India, especially in Vidarbha region, where I am from, also in Gujarat, northern India, Punjab, Haryana, We also have Telangana and some other tribal areas where the disease is very high. So approximately 300,000 neonates are born globally, and predominantly we find this in India, Nigeria, and Democratic Republic of Congo. The term actually includes homozygous, that is SS, as well as other combinations like SB-Thal. Then we have, thalassemia, along with we have the Punjab variant, which Madam has talked about. Now, until the 1970s, the protocols for managing sickle cell was quite weak, and that's why there was high maternal and fetal mortality. Nowadays, with newborn screening techniques, preventive measures such as vaccination and antibiotic prophylaxis, overall the disease outcomes and patient survival has improved. There is significant reduction. However, despite all the advances, the pregnancies in sickle cell disease is still associated with high clinical and obstetric complication compared to the general population. So that's why these pregnancies are very high risk, and we need to worry about them. Why? Because there are certain physiological adaptations in circulatory as well as hematological, renal, pulmonary systems. And this overburdens the organs that already have chronic injuries because of sickle cell disease. Thus, there will be complications like eclampsia, preeclampsia, and the occlusive crisis, acute chest syndrome, which is seen in sickle cell disease, will also increase. So we have these specific complications related to sickle cell disease, that is the crisis, the acute chest syndrome, the pregnancy-specific complications like thromboembolism, urinary tract infections, spontaneous abortions, hypertension, then increased chances of interventions like cesarean sections, low birth weight, and preterm babies. So these are the important complications which we need to look into. As you can see from various studies, the abortion rate is also quite high. As you can see, up to 33% as far as Jatkar et al. Has from India has reported. The maternal death could be as high as 10%. Painful crisis also is very frequently seen, up to the mark of 58%. Acute chest syndrome till 10 to 18%. Severe anemia in some patients may be seen even up to 75%. Jaundice, infections, and preeclampsia also are higher as compared to the general population. And if you can see the complications in the baby, the prematurity is as high as 50 to 70%. And it may be because of the low birth weight is there because of prematurity, or also because of growth restriction. Stillbirth rates as high as, in one of the study, it is till 25%. Neonatal death rate is up to 6.6% or 6% to 8%. And of course, because of all these complications, the 5-minute UbGy score below 7 is also high, up to 34 to 50%. So that is why these outcomes are so important. How to improve this outcome is by planning and by contraceptive choice. So till everything is optimized, you should advise the woman not to get pregnant. And optimization has to be done before she gets pregnant. So by preconceptional counseling, screening for pulmonary hypertension with echocardiography, incidence of pulmonary hypertension in these patients is quite high. The tricuspid regurgitant jet velocity of more than 2.5 meters per second is associated with high risk of pulmonary hypertension. So echocardiography has to be done for these patients, and screening should be performed if this has not been performed in the previous year. So it is very important that preconceptionally you examine this patient clinically, look for the blood pressure, the urine analysis, the renal and the liver function. You also have to look for the retinal screening has to be done for proliferative retinopathy, which is quite common in sickle cell disease patients, especially in patients with hemoglobin SC, which can lead to the loss of vision. Thus, we also have to look for, if these patients have been transfused number of times, then the ferritin levels will be high. So for that, look for the serum ferritin level. You can also go in for a magnetic resonance imaging to find out what is the iron load. So this is all prior to the pregnancy. you should do an aggressive chelation before the conception so that the iron load is reduced. It's very important that the patient is optimized before she go on to the pregnancy. Now, during pregnancy, and even prior to that, antibiotic prophylaxis with penicillin, oral penicillin 250 milligram BD is important because these women are prone for infections, and there is clear evidence that penicillin actually benefits. So you may give erythromycin if the patient is allergic to penicillin. However, penicillin is cheap and effective. Immunization, which can be done preconceptionally, is H influenza, meningococcal vaccines need to be given, pneumococcal, hepatitis B, and now COVID vaccine is also recommended in these women preconceptionally. But of course, swine flu and whatever influenza, whatever infection is going on currently, that vaccine has to be received by the patient. Prior to conception, the folic acid has to be increased to 5 milligram once daily. Previously, she may be receiving 1 milligram, but now you have to increase it to 5 milligram daily because the demands in the pregnancy is increasing and to reduce neural tube defect in these patients. So again, preconceptionally, you need to stop the hydroxyurea at least 3 months before the conception. These women receive hydroxyurea so as to decrease the acute painful crisis. This hydroxyurea, as Madam Jatkar has already said, is teratogenic in animals. Such kind of teratogenicity is not found in humans. Still, it is advised that the patient should stop using hydroxyurea 3 months prior to the conception. There have been published reports where the woman has been on hydroxyurea and she continued the drug and there was no side effect on the pregnancy. Thus, if the woman comes to you when she is on hydroxyurea and she has conceived, you should stop it. You can counsel her regarding, the structural abnormalities seen in animals, but not in humans. However, termination of pregnancy is not advised in these women because the anomalies are not seen in humans as yet. ACE inhibitors are being given to these women to reduce the proteinuria. This ACE inhibitors is not safe in pregnancy and it should be stopped in women who are trying to conceive. Now, what about antenatal care? Antenatal care has to be multidisciplinary with obstetrician and hematenologists both looking at the patient together. You look at screen for end organ damage, look at some precipitating factors, counsel the patient about these precipitating factors like extremes of temperature, dehydration, overexertion. And if there is persisting vomiting, that also can lead to dehydration and sickle cell crisis in women, in these pregnant women, and that's why we have to look into that. Now, it's very important to establish comprehensive centers like the center in IGMC. So wherever the prevalence is high, these centers should be available to look at these women so as to decrease these complications which are associated with sickle cell disease. So if good prenatal management is there, the nutritional status is improved, malaria prevention, early detection of bacterial infection, that is how it will have a positive impact on the morbidity and mortality of these women. How to screen? So as ma'am has already told you, you have to offer partner testing. So if this patient is HbAs, then the partner testing has to be done. And if the partner is also a carrier, then appropriate counseling regarding the prenatal diagnosis has to be done prior to 10 weeks of gestation. Screen not only for sickle cell, but also for thalassemia, HBC also. An option of first trimester diagnosis and termination can be given to the patient if the fetus turns out to be HbSS, that is the sickle cell disease. So that's important. From folic acid, I have already said, the drugs, the hydroxyurea and ACE inhibitors need to be stopped. Iron supplementation should be given only if iron deficiency is documented. Otherwise, the patient is already having iron overload. Calcium 1 gram per daily. You should start, consider starting low dose aspirin 75 milligram once a daily from 12 weeks of gestation to these women to reduce the incidence of preeclampsia. Prophylactic low molecular weight heparin should be given when the patient is admitted to you for some cause, maybe dehydration or acute chest syndrome, any complication is there and patient is getting admitted, at that time LMWH can be given. There are certain reports of increased venous thrombosis in this patient, and thus you need to screen if there are some risk factors. If there is an intermediate risk factor or patient is getting admitted to you, consider giving LMWH. For them, the LMWH. Additional care is required, blood pressure measurement and urine analysis. In fact, urine culture should be done monthly for these patients. It is very important so that you can diagnose infections early and treat early. Review what is the housing status, work status, or circumstances of the woman. And if there are certain conditions where the crisis may be provoked, you should talk about this to the woman and increase the allowance for hospital admission for these women. So it's very important that you support the women. The schedule of the scan: do a viability scan at 7 to 9 weeks, routine first trimester scan at 11 to 14 weeks, and detailed anomaly scan at 20 weeks, which we usually do for all our patients. But for these sickle cell disease women, we should be doing the growth scans every 4 weeks from 24 weeks onwards to detect early the fetal growth restriction in these women. So in the first appointment, offer the advice, information, support the woman, do the partner testing, take a proper clinical history regarding what drug she is taking, and offer vaccinations and screen the patient for retinal, renal, and cardiac problems. In 7 to 9 weeks, what you're doing is you're doing the ultrasound, you're again reviewing the partner's result, doing the basal renal function test, urine protein creatinine ratio, liver function test. And important here, when you're doing the RH phenotyping of this woman, do an extended phenotype so that you can identify other phenotypes also apart from RH. So that's very important. And from 16 to 28 weeks, you should examine this woman every 4 weekly. You should be doing her the urine analysis for culture, and you should be doing antenatal care and ultrasound examination for growth. So now here at 36 weeks, you identify if any problem are there, any growth restriction is there, the amniotic fluid volume is checked. And of course, here and now you decide what is the mode of delivery, time of delivery, anesthetic assessment, and you counsel the baby woman about care of the baby. At 38 to 40 weeks, you may do the induction for this patient or planned cesarean section. Now let us know about aspirin in sickle cell disease. There have been certain trials, and this is the Cochrane review of 2007, wherein 32,000 women were entered in this trial, and they found a moderate benefit, 15% reduction in preeclampsia in women who were started on low-dose aspirin. So it would be good if we can start these women on low-dose aspirin. What about prophylactic transfusion? It is not recommended. If acute exchange transfusion is required for treatment of a sickle cell complication, that means previously also she has been on a transfusion regime, then that regime has to be continued in the pregnancy also. And as I have already said, apart from RH typing, an extended phenotyping has to be done, like for C, D, E, and KEL typing. Otherwise, what happens? The patient may develop isoimmunization against these phenotypes, and later on, if she needs transfusion later on in her pregnancy, you may not be able to find, the correct blood to give her for transfusion. So that's very important that you do an extended phenotype of these women. Top of transfusions may be in these women who are having acute anemia, and this acute anemia may be because of red cell aplasia or splenic sequestration, increased hemolysis, and that's why acute anemia may be seen in these women. No absolute level at which transfusion should be undertaken is known. However, if the hemoglobin goes under 6 gram or there is a fall of over 2 gram per DL from the baseline, then transfusion is recommended. If there is a painful crisis, you need to, if your patient is very unwell, urgently you should be able to diagnose this painful crisis. Multidisciplinary management is needed for these women, appropriate analgesia, fluid will be needed. The fluid has to be assessed and given to the women in at least 60 ml per kg, oxygenation by mass 4 to 6 liter, and thromboprophylaxis. Now, you have to be careful with this woman. She may require an intensive care, and thus you have to be ready for this woman who may be needing HDU and ICU management. You need to assess this woman for complications like acute chest syndrome, sepsis, dehydration. And whenever these patients report to you and you find that they are unwell, you should ascertain the type of pain, what are the precipitating factors, site of pain, any atypical feature. Do certain lab investigations like full blood count, reticulocyte count, renal functions. You may also need to do an X-ray and urine culture for these women. Analgesia should be given within 30 minutes of arrival at the hospital, and you can follow this step ladder pattern of WHO for analgesia. If the pain is mild, can give paracetamol, weak opioids if there is a moderate pain, and stronger opioids like morphine can be given for severe pain. This morphine can be administered orally, subcutaneously, intramuscularly, or by intravenous route. It's very important that you give this pain control to these women who are having acute painful crisis. Pethidine is actually avoided in these patients because of risk of toxicity and pethidine-associated seizures which are seen in the sickle cell disease women. So this is an outline of management of acute pain. Rapid clinical assessment. If the pain is severe and oral analgesia is not effective, give strong opioids, give adjuvants. Also, laxative, antipruritic medication, antiemetic medication will be required. She may need to be sedated also. The respiratory rate, oxygen saturation has to be monitored, and rescue analgesia may be needed. So this patient needs a lot of monitoring and rescue analgesia, which you have to offer in time to this women. Other complications like acute syndrome, I think Dr. Nishad is going to speak about, but let us remember that the signs and symptoms are similar like pneumonia, and the treatment is intravenous antibiotics, oxygen, and blood transfusion. The patient may also have acute anemia, which is attributable to erythrovirus infection. So you have to remember that with this erythrovirus causes the red cell maturation arrest. Treatment is blood transfusion, and the patient has to be isolated. There is an added risk of vertical transmission to the fetus, and also you have to rule out malaria and splenic sequestration if the patient presents to you with acute anemia. Optimal timing of delivery, as I have already said, if everything is going fine, the fetus is growing well, then you may induce labor at 38 weeks of gestation, or you may plan a cesarean section. Vaginal delivery is not contraindicated in sickle cell disease, neither is VBAC. However, you should keep blood cross-match and ready with the extended phenotyping, as I have already said. If the woman has hip replacement because of avascular necrosis, it is important that you decide suitable positions for delivery. Now, there have been studies in various countries which have highlighted that there is increased perinatal mortality in the later stages of pregnancy. So going beyond 38 weeks of gestation is not recommended. You should terminate the pregnancy at around 38 weeks of gestation. So many studies are actually supporting vaginal delivery, but you have to weigh individually, and cesarean section can be decided upon obstetric indication. When the patient is in labor, remember that the delivery has to be done in a facility where complications can be managed. There has to be a multidisciplinary team. The woman has to be kept warm as well as hydrated, and she has to be monitored well in labor. There is increased chances of crisis, increased chances of dehydration, and thus though you have to keep the woman well hydrated and good monitoring. If the progress of the labor is good enough, you may allow a vaginal delivery, but if the progress is not good, consider a C-section in time. If she's not tolerating oral fluids, give IV fluids. Venous access may be sometimes difficult because she has been receiving so many transfusions. So you take the help of anesthetist to have an IV access. Oxygen should be given by mask. Attach a pulse oximeter and look at the saturation. If the saturation is falling below 94%, you have to be giving her oxygen to maintain the oxygenation. There, of course, you can start broad spectrum antibiotics and close observation is needed for these patients. As far as anesthesia is concerned, the anesthesia assessment should be done in the third trimester, late third trimester. Regional analgesia is recommended in these women. Avoid the use of pethidine, that is very important. Now, after delivery, the baby should be tested for sickle cell disease as early as possible. For the mother, maintaining the oxygen saturation is important, adequate fluid balance is important, and giving low molecular weight heparin 7 days post-discharge following vaginal delivery, and if it has been a cesarean section, then up to 6 weeks, the LMWH has to be given. And the thrombotic stockings have to be advised, and for pain, you should advise the pain medication. In these women, breastfeeding is recommended. There is no guideline to stop breastfeeding. Again, acute crisis and other complication you have to keep on monitoring so that the risk can be avoided for these women. As far as contraception, the progesterone-containing contraceptives are recommended. These are the oral pills, progesterone-containing pills, injectable contraceptives like Depo-Provera, and even the Mirena system can be used. Nowadays, the Chaya is available through the government that can be easily used for these women. You should avoid using the combined OC pills for these women. Barrier contraceptives are also good, but then you have to counsel them that they have to use it at each coitus correctly and appropriately. Now, regarding good governance in the hospital, each hospital should be having a protocol how to manage sickle cell disease patient. The multidisciplinary team should be available. Your staff also should be knowing and trained how to manage these women. So staff meaning your nursing staff and your support staff. And if there is a high prevalence area, then a good specialist center has to be available around. If it's a low prevalence area, then you can link with a good specialist center, and good networking and shared protocols can be used so that these women can be managed well. So to summarize, sickle cell disease with pregnancy is a high risk. Good quality healthcare is needed for these women for optimizing the outcome. The multidisciplinary team approach is important. And of course, the protocols have to be in place and have to be followed correctly. So to conclude, counseling of these women is important. Compliance to treatment, whatever you have advised, effective teamwork, and tender loving care. These are all the determinacies. With that, I conclude. Thank you. And please vote for me for Clinical Research Committee FOGSI. Thank you so much for patient listening.
Thank you, ma'am, for the very informative session. So the take-home messages are, as this is high-risk pregnancy, we should do preconceptional, all the tests, liver function test, kidney test, blood pressure, retinopathy, ferritin levels, and we should also rule out iron overload.
Mute. Dr. Renu, you're mute. You're muted.
Thank you, ma'am. As it is a high-risk pregnancy, so the patient should be preconceptionally tested for the blood pressure, urine analysis, liver function test, retinopathy, ferritin levels. As you have highlighted everything so nicely, MRI should be done for iron overload, and the antibiotic prophylaxis should be given as they are more prone to infection. And the antibiotic can be given penicillin, and the erythromycin is the safest. Vaccination should be done prophylactically for COVID, influenza. Folic acid should be increased to 5 milligram, and we should stop hydroxyurea and the hydroxycarbide 3 months before the pregnancy. We should take care of intrapartum care also nicely, and hydration should be well done during the during labor. And the postpartum, you have very much highlighted, highlighted for the contraception. We can give this. We should avoid the combined oral pills. Thank you, ma'am.
Thank you, Renu ma'am. Now we move on to next session. I hand over to my next MOC, Dr. Amber, who is a dynamic secretary of Jaunpur OBS and Gynae Society. Dr. Amber, please.
Thank you, ma'am. I extend my warm regards to all the respected dignitaries. Moving forward to the next topic, which is complications of sickle cell disease in pregnancy by Dr. Nishad Dhakate sir. To chair the session, we have Dr. Alka Mittal ma'am, but she got busy due to some emergency. So I request Dr. Seema Vashne ma'am to kindly introduce the sir and chair the session.
Okay, thank you, Dr. Amber. Now, it gives me immense pleasure to introduce a very distinguished and a very eminent speaker, Dr. Nishad. He is hematologist and BMT consultant, SCG NCHRI Cancer Center, Nagpur. He is director, Nagpur Hematology Center, Niti Gaurav Complex, Nagpur. His MD Medicine, KEM Hospital, Mumbai, DM SG PGI, Lucknow, and his fellow bone marrow transplant, RGCI, Delhi, and fellow leukemia and BMT, Canada. So over to Dr. Nishad for the complications in sickle cell disease. Dr. Nishad.
Thank you. Thank you for the kind introduction. At the outset, I would like to thank UP West Gynec and Obstetrics Society for giving me this opportunity to speak on this very important topic. I also thank Dr. Anuradha Shrikhande ma'am for giving me this opportunity for speaking on this very important topic, which is very close to my heart. I would like to share my screen. So it's a pleasure to speak on this forum since I am an alumni of SGPGI Lucknow. I would like to start by saying that there are 5 key important management decisions which need to be taken while managing a case of pregnancy in a patient with sickle cell disease. The first is IV fluids. Second is analgesia, good analgesia. Third is giving blood transfusion as and when required. Fourth is antibiotics. And fifth is oxygenation, which is very important. Now, motherhood is the biggest gift from nature. However, it comes with a cost, especially for those high-risk pregnancies, and sickle cell disease is one of them. We all know that a quarter century ago, sickle cell disease had a dismal prognosis. And pregnancy was not encouraged by us then. However, in 1998, with the advent of hydroxyurea, which proved to be a game changer, this molecule led to a reduction in painful crisis. It led to transfusion independency in some of them. It led to less hospital admissions and a good physical growth. This also led to decreased morbidity. Patients had a better quality of life, hence they had a better education, better jobs. They were financially independent and had an increased life expectancy. This also opened avenues for marriage. For boys, this is not a problem. However, for girls, this can be a hornet's nest, mainly because they get pregnant. And pregnancy in sickle cell disease, as we all know, is a high-risk pregnancy. This highlights the prevalence of sickle cell disease in central India. It is approximately 20 to 44%. So this is a huge burden. And so we all will come across patients with sickle cell disease being pregnant and handling them in day-to-day practice. With this background, as Dr. Shrikhande madam have already shown, that most pregnancies will likely terminate in a live birth. However, these pregnancies might develop a host of complications, and these include maternal as well as fetal complications. In the maternal side, they can have hypertensive syndromes such as preeclampsia or eclampsia, venous thromboembolism, which can lead to DVT or pulmonary embolism, preterm labor, it can lead to fetal loss. There can be repeated vaso-occlusive crisis, spontaneous miscarriage, antenatal hospitalizations. It can lead to increased chances of delivery by a cesarean section. We all know that they can have multiple urinary tract infections or infections by encapsulated bacteria, antepartum hemorrhage. In the fetal side, it can lead to perinatal mortality, intrauterine growth retardation, and preterm labor. Now, this slide shows you the various complications which a pregnant patient with sickle cell disease can suffer from. And this is where we as hematologists, we as obstetricians, we play a very important role in reducing these complications. Let me discuss a case which will highlight the number of complications and the various types of complications a sickle cell disease patient with pregnancy can suffer from. So this is a 19-year-old female with sickle cell disease SS pattern who presented at 10 weeks pregnancy. She had already discontinued hydroxyurea 5 months ago because of infrequent crisis and unprotected sex. So mind you that these infrequent crises were because of hydroxyurea which she was on. She was counseled for the complications of pregnancy when she came to us. Her partner was screened for hemoglobinopathy status. She was referred to a high-risk obstetrician team and a hematologist. Now she was scared mainly because her sister, who was also suffering from sickle cell disease, had a pregnancy with twins, and her sister required frequent admissions or hospitalizations because of acute vaso-occlusive crisis. She had a known cerebral aneurysm, and that is why she was scheduled for a elective cesarean section. But because of preeclampsia related complications, she delivered at 33 weeks. Her course was complicated by a massive pulmonary embolism requiring ICU admission. Her babies, which were twins, at neonatal intensive care unit stays because of prematurity, neonatal abstinence syndrome, and hemolytic disease of the newborn. Now, this patient also required several hospitalizations for acute painful crisis. She required blood transfusions for anemia at 24 weeks of gestation. She had a spontaneous rupture of membranes at 37 weeks of gestation and delivered a 3.2 kg healthy infant vaginally. She had an acute pain episode postpartum. This was complicated by a severe anemia with a hemoglobin of 2.8 with a new red cell antibody. She had not received CE-KEL matched blood transfusion. So this patient had developed alloimmunization and had acute a delayed hemolytic reaction because of a new red cell antibody which she had. Now, my further talk would be focusing on preconception counseling, the 3 trimesters of pregnancy, and the care required during postpartum. Here, I would like to highlight that we will be focusing on preventing complications, diagnosing, and then management of complications. Most of my talk has already been covered by Dr. Thaide. To recapitulate, it is important that we, right from the adolescent age, we start counseling these patients about how pregnancy affects sickle cell disease and how sickle cell disease affects pregnancy. It is important to counsel them about the contraceptive advice. Once they are married, we must screen them for various end organ damage and optimize their management. We should re-counsel them about the contraceptive methods and the various reproductive techniques which are now available. They should be vaccinated because of infections regarding infections due to encapsulated organisms. We should highlight the importance of crisis prevention and the need for immediate medical help if required. So these are the various reproductive techniques which should be highlighted. And it is important that the most important I would like to bring here is the pre-implantation genetic diagnosis. Many of the patients are not aware about this. Even the educated class of people need to be educated that a biopsy of pre-implantation embryo can be selected and transferred into the uterus, which can prevent the transmission of sickle cell disease. We can use the donor sperm from a male without a hemoglobinopathy. We can opt for prenatal diagnosis, that is chorionic villus sampling and amniocentesis. Again, surrogate pregnancy is another option, though not practiced in our country. There are two options: gestational carrier pregnancy and traditional carrier pregnancy. And the last thing is adoption. Now, we all know that commercial surrogate pregnancy is not advocated in India, but there is still a role of volunteer surrogate pregnancy in India, which can be practiced. And recently, the actress Priyanka Chopra was in news for surrogate pregnancy, and this option can well be explored by a sickle cell disease patient. We also need to highlight the importance of partner testing once the patient is married and is contemplating a pregnancy. We all know that if the partner is normal, the fetus is going to be 100% heterozygous. Whereas if the partner is heterozygous, there will be a 50% chance of having a pregnancy with sickle cell disease and a 50% chance of having a AS pattern. If the partner is also homozygous, there will be 100% chance of having a sickle cell disease patient. And by prenatal diagnosis, we can give them an option of aborting a medical termination of pregnancy. Now, once the patient is married, is contemplating pregnancy, education plays a very important role in crisis prevention. Here, we should highlight the role of dehydration, cold, hypoxia, extreme physical or overexertion in increasing the chances of sickle cell crisis. And as we all know, that in first trimester of pregnancy, patient can have increased tendency of nausea and vomiting, which can lead to dehydration and precipitation of crisis. There is also a risk of worsening anemia during pregnancy and increased risk of IUGR, baby, and of preterm labor. Now, it is very important for all of us to assess for complications of, to assess the end organ damage, which should be remembered by all of us. Here we need to do certain tests, which includes an echocardiography for assessing pulmonary hypertension, a routine testing for urine analysis and blood pressure to screen the patient for hypertension and proteinuria. Liver function test and renal function test should be done to look for sickle cell nephropathy, and deranged hepatic function to look for intrahepatic cholestasis, which can worsen during the pregnancy. Retinal screening should be done to look for proliferative retinopathy, screening for iron overload, as have already been highlighted by Dr. Taide. It should be done. Another important thing is to screen for red cell antibodies. Now, the simplest test which we can do is a Coombs test, direct Coombs test and an indirect Coombs test, which is readily available. Let me highlight that extended RH, extended red cell phenotyping is not available everywhere, and it is available only in big cities. In Nagpur, it is not available. In SGPGI, where I have studied, red cell antibodies can be typed, and we can screen for antibodies. We can also screen for KEL, DEL, Duffy, these minor blood groups, which play an important role in preventing hemolytic disease of the newborn. Nevertheless, triple H testing also should to be done. Now, before we embark on pregnancy, we need to optimize the medical management of pregnancy. And here it is very important to start the patient on penicillin prophylaxis, because these patients are at high risk of encapsulated organisms, which can be really life-threatening. Vaccination against Neisseria meningitidis, Streptococcus, H. influenzae, and hepatitis B should be done. Folic acid should be started immediately. Hydroxyurea, as I've already highlighted, should be stopped 3 months before conception. Angiotensin converting enzyme inhibitors and ARBs should also be stopped before conception. Now, the important thing is one should remember that if the patient gets pregnant on hydroxyurea, this does not really necessitate termination of pregnancy, because it has been seen on animal studies that there are anomalies, but in human studies there is scarce data, and also we can do a high anomaly scan to see whether if there are any anomalies which can be later decided. Now let's talk about the do's and don'ts of first trimester of pregnancy. Now, once the patient gets pregnant, again, education is very important. You should establish a multidisciplinary team, which includes a neonatologist, hematologist, a high-risk obstetrician, anesthesiologist for further management of the pregnancy. The previous all records should be reviewed and all medication should be reviewed. We should screen the partner if the partner has not been screened, it should be done immediately so that we can decide about the further course of pregnancy. Folic acid should be started immediately. Penicillin prophylaxis and vaccination should be done. Routine screening for bacteriuria should be done. Important complication which needs to be discussed is pregnancy-induced hypertension. Here, I would like to highlight that, these patients are at increased risk of pregnancy-induced hypertension and preeclampsia, and that is why at every visit, patients should be screened for proteinuria, and blood pressure needs to be measured and documented. It is important to say here that these patients often have a low blood pressure. So any upward trend in the blood pressure, even if it is very modest, should be monitored and carefully documented. The target blood pressure here would be less than 130/80 millimeters of mercury. And as already highlighted by Dr. Taide, aspirin should be started 75 to 150 mg daily from 12 weeks of gestation. This should not be forgotten. And aspirin can be stopped at 38 weeks, anticipating some postpartum hemorrhage. But however, this is controversial, and we can even continue the aspirin beyond 36 weeks. Now I'd like to discuss blood transfusion during pregnancy. Now it is important for us to remember that in most of the centers, we can only do ABO testing and direct and indirect Coombs tests to look for antibodies. Extended RH and KEL matched and CMV negative blood, though practiced by developed countries, is not available for most of us. And hence, we should rely on Coombs test, which is easily accessible. And patients who have red cell antibodies should be tested at a higher center to look for antibodies against the corresponding antigens, and those red cells should be selected which do not have the corresponding antigen. Now, prophylactic blood transfusion is not routinely recommended for sickle cell disease patients, but for those who have some medical, obstetric or fetal problem, they can undergo a blood transfusion. Usually, I practice transfusing blood if the hemoglobin is less than 6 grams%, or if there is an acute illness. Patients who have been on hydroxyurea because of some severe disease are another set of women who might need a transfusion. Multiple pregnancies, another reason. Now let's look at indications for acute transfusion. We all know that acute complications of sickle cell disease like stroke, ACS, and acute clinic sequestration, where the hemoglobin might drop suddenly, will require a blood transfusion. Another indication is when there is acute anemia, when there is a decrease in hemoglobin by 2 grams% because of any acute illness, can be one of the reasons for acute blood transfusion. Let's look at what are the indications of chronic transfusion. So some people, as some sickle cell disease patients, as we all know, have been put on chronic transfusion protocol by their physicians and hematologists, especially those who have had stroke in the past. So these patients should be continued on a chronic transfusion protocol, which is usually once in a month or once in 45 days. Twin pregnancy is another reason. Patients who have had sickle cell disease related complications in their previous pregnancy can be put on chronic transfusion, and patients who have repeated acute chest syndrome or repeated acute vaso-occlusive crisis are another subset of patients who can be put on chronic transfusion. Now, how to manage acute pain episodes during pregnancy? Now, as we all know, there are more than 50% of the women will have an acute painful crisis during pregnancy. If they are having mild pain, this can be managed with rest, oral fluids, and paracetamol. However, if the pain is mild, moderate to severe, you should advise them for a brief admission and then treat them with NSAIDs and non-opioid and opioid analgesics. It should be remembered here that NSAIDs should be used with caution in the first trimester and after 31 weeks of gestation due to the risk of premature closure of patent ductus arteriosus. For severe pain, morphine, diamorphine, or oxycodone can be used. However, morphine, oxycodone are not routinely available to all of us. They are mainly available in cancer centers. So tramadol, codeine, which is easily available, can be used instead of morphine. And as I have already said, there are 5 key management points you should remember. And first is IV fluids. Second is a very good analgesia. Third is oxygenation. Fourth is antibiotics, because most of these acute pain episodes will be precipitated by an acute infection. And the fifth is blood transfusion as and when indicated. So you should assess for precipitating factors for acute vaso-occlusive crisis, and usually it is an infection. So you should cover the patient with antibiotics. You should use IV fluids, and dehydration should be avoided. Adequate oxygenation, as already highlighted, and assess the risk of acute chest syndrome and pulmonary embolism. You should advise them to start spirometry as soon as possible, so that it decreases the chances of acute chest syndrome. So incentive spirometry is what is recommended. Assess for infections, treat antibiotics if they are febrile, and this, as already highlighted, thromboprophylaxis should be prescribed for women with sickle cell disease. Now, what should be the dose? So usually we start the patient on low molecular weight heparin, 40 milligrams subcutaneous once a day, to cover the duration of hospitalization, and it can be stopped later on. Now, coming to management of acute chest syndrome. Acute chest syndrome usually presents with fever and respiratory symptoms. It usually resembles a pneumonia or a lower respiratory tract infection. It is very important for us to do a blood culture, look for the exact microorganism which may be responsible for ACS. Sputum and culture should be, sputum for microscopy and culture should be sent. Basic management should include immediate pain relief, incentive spirometry, and oxygenation. Antibiotics should cover atypical organisms. The usual antibiotics which we use are a broad spectrum antibiotic like piperacillin tazobactam, and to cover atypical organisms, we usually add levofloxacin. Simple top-up transfusion may be required in acute chest syndrome. Exchange transfusion is necessary only if there are severe clinical features, or despite of all measures, the patient has a progressive course. Now let's talk about management of VT and thromboprophylaxis. We all know that the chances of VT, including deep vein thrombosis and pulmonary embolism, is high in a patient with sickle cell disease and pregnancy. So risk assessment should be performed early. Prophylactic low molecular weight heparin should be started from 28 weeks of pregnancy until 6 weeks postpartum. I don't know how many of you all practice this, but this is highly recommended to prevent DVT, and it is very important learning curve from this presentation. Compression stocking should be used, and low molecular weight heparin should be advocated throughout admission if there is an admission because of acute illness. Now, these are certain parameters to be tested during the first trimester. We should have a baseline SpO2, blood pressure, hemoglobin phenotyping and genotyping. If the patient is having anemia, a reticulocyte count should be tested so that we type the anemia, whether it is because of iron deficiency, whether it is because of pure red cell aplasia because of parvovirus infection, or whether it is because of some nutritional deficiency needs to be ascertained before correcting the anemia. This is the simplest test, which I've already pointed out, that a direct Coombs and indirect Coombs test should be done in all the patients to know if the patient is having any red cell antibodies. Assess for end organ damage during the first trimester. During the second trimester, we should revise the plans already made during the first trimester, develop a plan for cesarean section, educate the mother and her supporting system about the complications that can happen during pregnancy, both for the mother as well as the baby. We should communicate our plans to the multidisciplinary team, treat iron deficiency anemia if it is there. During the third trimester, it is important to involve the neonatologist and discuss our plans about the mode and timing of delivery. We should revise the plans about delivery, including plan for cesarean section or a normal vaginal delivery. These are certain tests which we have already discussed. Intrapartum care, it is important to remember that sickle cell disease with pregnancy is not a contraindication to attempting vaginal delivery, and a thoughtful decision should be taken seeing all the risk factors and the clinical scenario. There should be cross-match for delivery if there are atypical antibodies, and it should be remembered that if the patient is having antibodies, it could also lead to hemolytic disease of the newborn, and newborn screening should be done for anemia as well as hemoglobinopathy. We should all advocate institutional or hospital delivery. Women should be kept warm to prevent vaso-occlusive crisis and to avoid dehydration. Anesthetics team should be involved. Again, to highlight, the use of pethidine should be avoided. However, other opioids can be easily used. Regional anesthesia can be used for cesarean section. Postpartum screening, the newborn baby should be screened for hemoglobinopathies. During the postpartum period, to avoid vaso-occlusive crisis, maternal oxygenation should be maintained above 94%, and it should be practiced in all the patients that adequate analgesia and adequate oxygenation is the key to prevent complications. Low molecular weight heparin should be used post-discharge for a period of 6 weeks following cesarean section. And these are my references, and I thank for giving me this opportunity, and I would be glad to take any questions.
Thank you, sir. Thank you for the lovely presentation and very exhaustive. Before moving to the last part of the webinar, I want to invite Dr. Deepika to play a video on anemia awareness. It's a small video.
I think wonderful take-home messages, Dr. Nishad. Wonderful.
Introducing, for the first time in India, micronized dydrogesterone, DIVATRONE. For a safer and smoother journey to motherhood, Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for DIVATRONE.
My teammate is over here from our sales department, Mr. Kamal Bish.
Good evening to all the respected doctors. I am Kamal Singh, Regional Sales Manager, Jagsonpal Pharma for Western UP and Uttarakhand. We thank you for this opportunity to connect with you to all through this webinar. We proudly present DIVATRONE 10 mg tablet, micronized dydrogesterone, which Jagsonpal manufacturing after years of research and development. makes all the quality API of dydrogesterone with the all intermediate, making India Atmanirbhar for producing this critical API. The quality of our brand DIVATRONE 10 mg is backed by the bioequivalence study to prove its clinical efficacy and safety. Moreover, the clinical advantage of DIVATRONE in offering safer and smoother journey to motherhood. Our indigenous API offers remarkable reduction in the cost to the patient, providing more economical therapy at just ₹50 per tablet, almost 32% more affordable than our innovator brand. DIVATRONE is readily available to all the counters near you to prescribe. Our sales team visiting you to continuously starving to make you bulk purchases, experience effortless and worthwhile. We also present JP Tone syrup, our iron therapy enriched with zinc and vitamin B complex. So bring back the colors of joy in her life with the JP Tone syrup. As a member of Jagsonpal family, I feel really proud that we are continuously working in the direction to make pregnancy easier with the addition of DIVATRONE, micronized dydrogesterone 10 mg tablet to our patient. Once again requesting your support for the new brand DIVATRONE. Thank you very much.
Last but not the least, a very important topic on anemia awareness by very knowledgeable Dr. Rashmi Kharotkar madam. To chair the session, I welcome Dr. Namrata Bhardwaj ma'am, who is a very renowned practitioner from Aligarh, and madam has won several awards for paper presentations in various conferences, and she has delivered the prestigious Kamini Rao oration at AICOG Calcutta. She has various publications in reputed journals, and currently ma'am is treasurer Aligarh ObGy Society. I request ma'am to kindly introduce our speaker and chair the session.
Thank you, Dr. Amber. Thank you all the organizers for making me part of this wonderful, wonderful academic treat. We have all been listening to stalwarts talking about various kinds of anemia, and it boils down to the same thing, anemia. So I have pleasure of introducing Dr. Rashmi Kharotkar, who will be talking on anemia awareness. Just to cut a very, very long list of accomplishments short, madam is a consultant OB-GYN at Amravati, is a joint secretary of ISOPARB.
Thank you, madam. Thank you, madam. It's all right, ma'am. Thank you, ma'am. I'm all yours, ma'am.
Okay,
I'm
Rashmi,
all yours. Yeah.
Okay, Dr. Rashmi, please welcome, ma'am.
Yeah,
please
thank you.
Start.
Thank you, my dearest chairperson. Thank you, respected Dr. Archana Verma, madam, for including me this beautiful webinar. I extend my respects to Dr. Bipin Pandit sir and Usha Sharma, madam, and my beloved teachers, Dr. Alka Patankar, madam, Dr. Anuradha Shrikhande, madam, Dr. Surekha Taide, and Dr. Dhakkate. So I will be talking about how we can create awareness about anemia in general population as a medical practitioner, and what can we teach to our healthcare workers who work in the periphery. This topic will exclusively exclude hemoglobinopathies because we have already learned lots of from our stalwarts today. As we all know, anemia is the commonest hematological disorder that occurs in pregnancy and is characterized by insufficient hemoglobin to carry out oxygen requirement of tissues. For all practical purposes, for developing countries, to define anemia, the cutoff level of hemoglobin is suggested as 10 gram%. Next, please. Anemia is a very serious public health concern. Why? Because it affects pregnant women and children mostly. According to WHO, 42% of children less than 5 years of age and 40% of pregnant women worldwide are anemic. Next, please. The magnitude of this problem is such that in developing countries, and of course in India, the incidence is very high, so high that it accounts for nearly 40% maternal deaths and is a major cause of direct and indirect maternal mortality. As we all know, it presents with lack of concentration, infection, palpitations, dizziness, weakness, fatigue, irritability. Next, please. Next slide, please. And we could get a soft ejection systolic murmur, tachycardia, glossitis, nail changes, edema, and of course, pallor of the skin in patient. Next, please. We label it as a moderate type of anemia when the hemoglobin ranges between 7 to 10.9 gram%, severe when it is It ranges between 4 and 4 to 6.9, and very severe when it is less than 4 gram%. Next. And we also can classify it if it's physiological and pathological, and the pathological variety includes majorly nutritional, hemorrhagic, and hemolytic anemia. So we will be majorly concentrating on the nutritional type of anemia, which is more prevalent in our country. It is a major health problem affecting pregnant women, lactating mothers, PNC patients who are our family planning acceptors, and children within 1 to 11 years of age. Next, please. So why there is so much incidence of anemia in our country? So the probable reasons could be, we have a low socioeconomic status and poor hygiene. We have chronic malnutrition. There is poor availability of iron due to predominantly vegetarian diet, which is low in calories but rich in phytates food, and there are some religious taboos, and majority of them have gastrointestinal tract infections and infestations like Kala Azar, worm infestations, etc. Next. And generally our patients have poor pre-pregnancy iron balance due to untreated systemic diseases and menstrual disorders. There is improper supplementation of iron in pregnancy. Why? Because our patients get registered late and the follow-up is also poor. There is repeated childbearing also adds to the problem, and actually there is lack of awareness and illiteracy. Next, please. So Anemia Mukt Bharat, has suggested us a 6-point intervention strategy to combat the anemia. So the points are, first, next please. We have to prophylactically give iron folic acid supplementations, and depending upon the age group of the patient, we have to categorize and systematically calculate the dose, and as per the dose, we have to give prophylactic iron and folic acids to children, adolescents, and young reproductive age group patients. Next, please. Next, please. We have to know that all women in the reproductive age group in the preconception period and up to the first trimester of the pregnancy are advised to have 400 microgram of folic acid tablets daily along with iron. Next, please. The other modality of intervention to combat anemia is advocating some behavioral changes in our population. For example, the compliance to iron folic acid supplements should be increased. There should be regular deworming of the patients. Appropriate infant and young child feeding practices should be advocated. We should advocate to increase the intake of iron-rich, protein-rich, and vitamin C-rich foods through diet diversifications and consumptions of fortified foods. And we all, as obstetrician and gynecologists, we all know that we practice delayed cord clamping in all healthcare facilities, followed by early initiation of breastfeeding within 1 hour of birth. Next, please. Another important intervention would be testing, test and treat strategy. So in this intervention, we can use digital hemoglobinometers in our periphery. Especially we can start using digital hemoglobinometers in 2 age groups, to begin with school-going adolescents and pregnant women. And then we can really increase our area and make it available for general population. Next, please. The next intervention strategy will be mandatory provision of iron and folic acid fortified foods in government-funded health programs. Next, please. And the next intervention, sixth intervention would be we should be intensifying awareness, screening and treatment of non-nutritional causes of anemia in endemic pockets, with special focus on malaria and other hemoglobinopathies and fluorosis. Next, please. We as doctor, as healthcare provider, can act and can have a major role in spreading awareness to combat anemia. Next, please. How we can do it? We can raise awareness by routinely screening the patients for hemoglobinopathies on their first visit only, irrespective of the genetic or area-wise predisposition to the disease. we can advocate and we can spread awareness about preconception genetic counseling, slogans, posters, poem competitions, and education of our healthcare workers at periphery. I would like to say on this platform that Vidarbha ISOPARB chapter, which has recently taken over, we have started a community project. In this community project, we will be going to the periphery and we will be educating our Anganwadi workers and Asha workers, who are the basic grassroots workers, to go to the women in the society, and we will teach them basics and basics like checking hemoglobin, taking PP. This is a community project we have taken. Next, please. So there are some points I would like to stress to conclude that anemia, although preventable, is a global problem. Anemia still is the commonest cause of maternal mortality and morbidity, in spite of easy diagnosis and treatment. It can be due to a number of causes, including certain diseases or shortage of iron, folic acid, or vitamin B12. The most common cause of anemia in pregnancy is iron deficiency. And next, please. Iron therapy is best given orally. Next slide, please. The youth need to be educated about diet, sanitation, and personal hygiene. Hookworm infestation should be treated, and pregnant women should essentially be given iron and folic acid supplements. Thank you very much.
Thank you, Dr. Rashmi, for a wonderful, wonderful presentation, because what we do need now is a community-based approach. Not everything we can do sitting in our clinics. Just to summarize, there's no need to summarize, you've presented beautifully, Doctor, but your 6-point approach was beautiful. I think if we can employ that, if we can deploy it in our community, we can have really have an anemia Mukt Bharat. And thank you very much for this.
Thank you, sir. Thank you so much.
Thank you, ma'am, for the lovely talk. And now I request Seema ma'am to give vote of thanks. And
thanks to Chief Guest, Dr. Usha Sharma ma'am, and guest of honor and backbone of Best UP ISOPARB, Dr. Archana Verma ma'am. Really salute to her, who gives opportunity to share this platform with so many stalwarts and very, very important topics. Thank you so much, Dr. Archana Verma ma'am, and thank you, Dr. Bipin Pandit, for coming and joining us and giving your precious time, and all the eminent speakers who have given wonderful, very informative and very useful oration on hemoglobinopathies, and especially Dr. Rashmi, who have coordinated all faculties, and really a very wonderful webinar and very informative webinar. Dr. Anuradha, Dr. Alka, Dr. Nisha, Dr. Smita, and Dr. Rashmi. Thank you so much from my core of my heart. It is a very good informative webinar. And all the chairperson, Dr. Manisha Agrawal, Dr. Archana Sharma, Dr. Renu Bansal, Dr. Alka Mittal, although she was not able to present, she was very busy somewhere, so no problem. And Dr. Namrata Bharadwaj. And all the MOCs, Dr. Ritu Arya, Dr. Amber, and Dr. Neha, thank you so much for coordinating so well. And last but not the least, all the attendees who have joined us and who have listened all the orations. And last but not the least, Jagsonpal team, our academic partner, and especially Dr. Deepika, who is ready every time for every help. Thank you so much. So we are looking forward to see you and arranging you all the webinars. So thank you so much.
Sure, so much. Thank you. Thank you very much, ma'am. Okay, so we at Jagsonpal request your wholehearted support to our product DIVATRONE, which is a newly launched dydrogesterone brand, for a safer and smoother journey to motherhood.
Don't even worry. Now we will be using DIVATRONE only.
Thank you. Besides our trusted and tried injection maintain and Lycorate Preg sachets. So for high-risk pregnancies, do remember these brands. And we look forward to your presence in all our other programs also, like the next web series that is starting this Thursday, 10th of February, 7 to 8 p.m. Just one talk by one key opinion leader This will be a series which is organized by SMLM Society. So do join us. Please note down the webinar ID displayed. Thank you so very much, and thank you very much, Dr. Archana Verma ma'am and the team West UP.
Tata, bye bye. All the best. Take care. Good night.